Most of us,
Okay.
most of us who wanted to go could not attend the convention due to various personal reasons. So we look forward to her inputs on what happened there. Though we know there was a lot of excitement on the mental health booth. Over to you, Bonnie.
Thank you. Well, Geetha was there. I can't look at my phone. Is Alan on the call? Or no?
Alan, is he there? I don't think he's there.
No, Alan has not joined.
No.
Okay. So you've got Geetha and I who were there. We had over 200 people who actually gave us their name and email. So Alan was able to get back to them immediately after the convention. And we're trying to discover what their interest is. We had a sheet that when some people completed it, you know, a lot of people gave us the basics and then didn't complete the whole sheet. But but you know, is your interest general mental health? Is your interest in our toolkits? Is your interest in forming a chapter? You know, are you a mental health professional, or have you been a mental health professional, etc. And we're getting a nice little profile of people who visited our booth. And to have data on over 200 people is just wonderful. We've never been able to have that before. Alan was extremely organized. And I do have to say that Geetha, and specifically Jay, her husband, are great member recruiters at a booth at the International Convention. This is not the first year where Jay has pried open someone's wallet and had them join our group. He's wonderful. Yeah. I'm hearing feedback. Is it me? No? Okay. We had presentations scheduled almost every hour because we supported and purchased the hub ourselves this year. We did not share it with another action group. So that gave us the opportunity to have a presentation almost every single hour, Saturday through Wednesday. It was 9 to 6, Saturday, Sunday, Monday, Tuesday, and Wednesday 9 until 2. I would say our pièce de résistance was past RI President Gordon McAnally. He actually took a double slot, and it was right before our scheduled annual meeting, which we packed the room for. And actually, they were very firm about not exceeding headcount in the room. And we know a few people couldn't get in the room who had wanted to be at the annual meeting. But we tried to social media to post and describe different sessions. And actually, Gordon's video is there. His whole 45 minutes is on our Facebook page. And as always, Gordon was highly inspiring. Of course, down to earth. He's just so wonderful. He's a people's president for sure. A lot like Francesco's going to be this year. So that's a synopsis. And Geetha, do you want to add more?
So the success, I think, of our group, it rests on the shoulders of many. It is not due to one person. It's both the people who are working the booth and people who spread the word and people who really are genuinely interested in doing something about mental health. So it was a mix of many kinds of people there. I think the other thing that's helped us is having high visibility in the hub. That didn't used to be the case, where we would be in one room somewhere away and you'd get a handful of people. Now, people, and the way the Rotary International has grouped the different exhibits, disease management is one area, water and sanitation is another area. So they have grouped it according to areas of focus, which makes it, I think, very helpful for people who are interested in disease management to get to that hub. Having the hub and having a prominent display of our sessions, I think, made a major difference. The next thing is that, people you have to do a lot of things in the background to make sure you have your audience. For example, when we pay for the hub, we pay for a certain number of seats to be in the area where people can be seated and listen. So there's a tendency for people around us to just grab the seat. So we went on a seat hunt and made sure they returned our seats. So sometimes it's funny. I would just walk into a booth and say, "Excuse me, the green chairs are ours. You got to give them back." So it was actually very nicely attended. But I think besides Gordon, Felix's presentation, I think it rang somewhere true to so many people's personal concerns, where his topic of how to solve a problem was just the maximally attended, because it didn't speak to any particular psychiatric condition or disorder. It spoke to simply being human. How do you solve a problem? It was packed. So definitely much more attendance, much more interest, and many, many more requests for information. That is true. So I just wanted to add that. Thank you.
Yeah. Thank you. Bonnie, would you like to say something more?
What Geetha is referring to is our PIP toolkit. And as I usually say when I'm exhibiting at a zone institute or a district conference or appels, is if you have conflict that may exist in your club, this is a great tool to begin to work on managing that. And as Geetha said, it's for everybody. It's not just a medical condition. It's not just a Rotary thing. It is a human thing that we have a toolkit for.
Thank you. So that was all about the Rotary Action Group on Mental Health at the Calgary Convention. And we look forward to more participation at the next year's convention in Taiwan. I already hear that 30,000 people have already registered for it, 30,000 plus. And I think we can expect a huge rush from the Asian countries because of the distance being closer geographically. So we look forward to that. And yes, Geetha, as you said, the hub is an added attraction, which we had from Singapore. But I'm sure this year they streamlined the systems in a better way than they did at Singapore. And that's a new introduction to us. So our visibility goes up. With 27 presentations by people, I think it's awesome. So congratulations to all of you who manned the booth and the hub and worked extremely hard. Alan, especially our Vice Chair, Alan Turner, he's not here today, but he'll join from next time, he said. So thank you for that. And now I would request Dr. Geetha Jayaram, who's a retired professor and psychiatrist from Johns Hopkins University, and she's our founding chair, and she's our star member of the action group. We rely on her on everything. She's the go-to person if we have problems in definitions and problems in anything we want to clarify. And I would request, Geetha is like a workhorse. Even after her retirement, I think she's busier than she was while she was working. And she's a wonderful human being. You won't believe it, because I didn't believe it, that she's working on 78 global grants. That's inhuman. That's almost inhuman. But over
No,
to
Rita,
you.
I'm not doing the grants. I'm guiding.
I
I've
know.
done some of them, but I'm not doing the grants.
But I would go mad doing even 2 global grants, and you're doing 78. So we would like you to share with our members today your work in Guatemala, which you have been doing for so many years now. So over to you, Geetha.
Okay, thank you, Rita. Just want to give you all a bit of a background. I'm not fully retired yet. I'm still teaching. And just this weekend, 3 previous residents called me for guidance on career issues. As you know, things are in total chaos in this country. If you haven't seen already and not experienced it, you are lucky. So there are people who are just out of jobs with absolutely no notice. So it's a really difficult time. At any rate, I've been a district governor. I'm finishing up as my district foundation chair. So it's given me it's a steep learning curve, and it's given me a lot of opportunity to understand what's really involved when people approve global grants at the grants officers level at RI. So I just want to give you a brief introduction of what it takes. I mean, first, we teach people this, when you want to do a project in another country, there is no substitute for making a personal visit there to see what goes on. So you've got to identify your partner in the other country. You've got to make sure you understand and work with them collaboratively. You have to understand they are committed to it just as you are, and they will carry on as the host country, carry on the project. You must know what exactly the needs are of the people you're going to treat. What is your target population? Who's going to do what at what time and by what means? And how are they going to assess outcomes? Who are the players in the community who actually help you in terms of carrying your project forward? So why did we choose Guatemala? If some of you might remember that Steve Dudenhofer was, besides Rita, also a Rotary man of action at the last convention. Steve approached me and said, Geetha, I know of your work in other countries. Can you help us in Guatemala, which is what got us started here? Now, you have to understand that, one of the problems across the world, even in this country, are that the same deterrents for access to care exist regardless of the country. So poverty, lack of access, lack of transportation, lack of knowledge about what is a psychiatric illness, lack of education in terms of literacy levels, all of it affects it. So in Guatemala, Steve wanted us to work with 2 boarding schools he has established for both girls and boys, but primarily for young girls who are, frankly, completely illiterate, severely abused, sexually and physically exploited, and typically do not leave home for any education unless someone helps them. So they have a lack of infrastructure, weak networking among care providers, and they have as well a critical need for psychiatric treatment where, and I'll show you some slides to show how the need for treatment of depression and anxiety has been exacerbated in the last few years, where suicide rates have gone up, primarily in young girls. So the next thing you need to decide is, what is the team that's going to go there? What kind of expertise does the team have? And do we have the ability to understand the culture and the language? So for me, my key person was one of my mentees who also served on the board of trustees of my organization, Herman Velez. Hats off to Herman. Herman is a child psychiatrist and a community psychiatrist like me at Cornell and Columbia University. He came with me, and he was instrumental in helping us with the communication with that district and with all of the stakeholders. So I'm going to just show you a few slides. I'm not going to keep you too long. Hopefully you'll understand what this comes from. And if you could, Saurish, allow me to share my screen, please. I will share it. Can you see it if I share it? You able to see it?
Yes, you can see the
Okay.
screen.
Yes, we can.
All right. So you see the young kids. I will not play this video, it takes time, but you will see the young girls who are there are mainly of the indigenous population and are of Mayan descent, and they speak a local language called Quechua. The majority of that population in the region that we targeted, called Petén, is in rural areas. So they have a great deal of difficulty accessing any service at all. Forget about mental health, they can't get even regular health care services. At one time in the past, this area was very rich with both archaeological and biological wealth, and had been the cradle of the Maya civilization, but it has really declined to a point where basic amenities don't exist. So this is the red and the blue are the two different genders. The males are in red, the women are in blue, and you see the population is divided just about equally between men and women. What is the socioeconomic profile? They have severe poverty. Close to 70% of the population can be qualified as poor, meaning they have really no access to even a complete nutritional meal once a day. The multi-dimensional poverty incidence is 81.9%, and the literacy rate with both men and women is average schooling of 5 some years, which is abysmal. So what happens is they can't, even if you give them directions, they can't read and write unless they go to school and they're taught something, which is why Steve opened up the school there. So we looked at another factor that's a major issue in this region, and that is the level of teenage pregnancy. So they were you can see here, this is the data we gathered from their local municipality, over 9,000 girls pregnant between the ages of 15 and 19, and 365 pregnant between the ages of 10 and 14. What then happens is that there's clearly a very high rate of maternal and infant mortality, if that's the case. And one of the problems has been that if they lived with their parents, they just don't pay any attention to this. There are public health reports of depression and increasing rates of suicide. The blue is the girls, the orange is the girls. There's an increasing rate of suicide in the girls. The National Primary Care Provider Survey showed that anywhere between 60 and 70% say there is absolutely no access to mental health care. This is the entrance to the school where the children were lined up welcoming us, and it was a beautiful display of warmth and hospitality by these children. And I'm just showing you the map of how we created the stakeholder diagram, starting from the school to the educational advisors, coordinators, the district education office, the deputy secretary of education, all the way up to the office of vice president. We did two things. We conducted both personal interviews as well as focus groups with the students, with the student teachers, with the counselors, with the educational coordinators. And this is just something to show you. We used several tools, but the Patient Health Questionnaire 9 is the most frequently used assessment of depression or general well-being across the world. And we found that if we use something very specific, like the ADAP questionnaire, which is done at Hopkins, or frankly, if we had used something that Bob uses in his toolkit, it wouldn't translate very well with the school. So we had to give up doing the ADAP, which was a lot more complicated for them to answer. And we did the PHQ translation, and we did the validation by translating into the language and back translating into English. So here's what we found. Close to 50% of the girls had depression of some level. and moderate to, at least 10% had moderate to severe depression that was untreated, which means when we interviewed them, they actually said they had suicidal ideation and a plan of how they were going to commit suicide. Besides Herman, whom you see here interviewing the children in their outdoor classroom, I had a translator who could speak the Quechua language, who interpreted and who didn't interpret, but translated for me, because he too had a hard time in not giving me his personal input on what might be going on. So this is Herman talking to the school teachers. And when we did the adolescent depression awareness program with the teachers, because they were better educated, just a couple of things. 81% of the teachers thought that most adolescents with depression will get better without treatment. And 69% of the teachers thought that people with depression can just snap out of it if they work hard enough. 81% of them thought that if their friend tells you they're thinking about suicide, it's important to keep it a secret. So you just see how these things are not peculiar to just this population. It's the same across the world. So I'm just showing you a couple of things that you would understand. So a lot of the children said that many of them are severely traumatized children with severe neglect or physical or sexual abuse. Many of them were afraid to speak and thought that they would harm themselves or their families. And this happens in victims of any abuse. The children were more protective of their families, particularly their mothers, in order to just keep everything a secret and not talk about it. So we met with the local school coordinators. I was just surprised at how many of them there were. So the health office has these school coordinators who could be an extraordinary resource in teaching or screening for depression, yet they had not been taught or educated to screen in that capacity. What we found was that there were many systems issues. The schools were not prepared to deal with suicide in the school community. School directors are notified directly and they just take them to the hospital if they think somebody is going to be imminently suicidal. There is no teaching about suicide. There's no post-suicide intervention. They're simply because of the lack of education, they said they would welcome any workshop, especially designed around the topic of suicide. So this is pretty much a diagram showing you how the networking is. We had prepared it in such a way that if I clicked on these meeting squares, it would open up into an actual video of how the meeting went. We haven't advanced it to that degree yet. So what did we do when we met with the local health office? There was one psychologist at the health office, and there were physicians, but they were not psychiatrically trained. The psychologist did most of the community outreach. There were no records except a few handwritten records, no digital communication, and very limited infrastructure. The local physician there could prescribe psychiatric medications, but a number of those medicines were not always available to them. And we met with the health area officer, who'd be called either the health commissioner here in the US, or they would be called the health officer in the US. We met with them, and they had a lot of positions that could have helped these children that were completely unfilled. So many people didn't want to work in rural areas. This is not uncommon. Even in India, fully trained residents do not want to work in rural areas. They all are concentrated in urban areas. That's about the same in the United States. If somebody offered them a bonus to serve in underserved areas, they may do it, but that's not the case over there. So essentially, the result of the needs assessment is very high mental health needs, limited access to mental health services, but above all, a huge stigma about mental health with a lot of misconceptions and biased beliefs that we have to work on when we go back. So I'm going to stop there and close this out and take any questions if you have any, because you have a limited amount of time. Now, what are the commonalities? There are many commonalities between India, where our clinic has run for 27 years now, and here, but our clinic 27 years ago had some of these same issues. There is progress possible if they are able to use technology to their advantage. So in our global grant application, we have requested computers, and we will be able to ask for some of the amenities that might help them maintain digital records, help them communicate with the local hospital or health department. Slightly different issues in about the same issues in Kenya. So I think rural Guatemala was comparable to rural Kenya. But in Kenya, the added advantage we had was that they spoke English. It was very easy to communicate because they understood and spoke English, and they were very eager to learn. But we were able to carry through some additional teaching in Kenya through Zoom because we provided them with computers, and they were able to actually see via computers what's going on. So there's a lot to be done, and I'm hoping Herman, with all of the craziness about sending people back to their homes, I hope they don't send him back to Bogota, Colombia, from where he is. And I'm really hoping that his visa status will be confirmed, because he's an extraordinary psychiatrist, and it would be sad to not have him participate. So I'm going to stop here. Thank you for the opportunity to speak to you all, and happy to answer any questions if you have any.
Yeah. Thank you, Geetha. May I request you to just close your screen, please?
Okay.
Yeah, thank you.
Okay.
So that was a daunting picture which you presented about Guatemala, their poverty levels, the mental health needs, nutritional needs, educational levels, and everything. I would open this house for questions. If anybody wants to ask Geetha, please do. Just raise your hand.
In the reaction, you can look at the reaction at the bottom and click raise your hand, and then I can see it.
But who is sharing the screen, please? I would request you to close the screen, stop sharing.
Load.
Who's J Lower? Please close your screen.
Yeah, that's better. So,
And no one has any questions. Well, that's not a bad idea.
all right. So
it's Greg. It's a little, thank you, Geetha. That was really kind of speechless at the moment. So my apologies for an absence of questions.
I mean, clearly people are very quiet because is this scary? Is it daunting? I mean, what's the issue?
no, we have a hand raised by Charles.
Yeah, there, Charles, go ahead.
Charles, go ahead.
Yes, I'm Charles from Bangkok, Thailand. I have a question about, you mentioned about the overall situation over there. In terms of global grant, can you briefly explain to us what are their needs and what is the solution? What if there's a grant, right? What are the focus? What are the area that we want to address? Who are the beneficiary?
So this falls under the area of disease prevention. And what we are proposing is train the trainer. So if we have been very successful in training local women caseworkers in India, in Kenya, and in some parts of Lithuania, where they go out and screen for and identify common mental disorders. Pretty much across the world, that's depression with or without anxiety, and alcoholism or substance abuse. That's the case across the world. Now, there is a way to train people who live in the community, work in the community, can communicate with people in the community to figure out what might be a disorder and get them to treatment. Excuse me, this. So one of the issues for us is there are no local women caseworkers there, but there are women teachers, there are other teachers, male teachers, and the women in the Rotary Club of Petan Tekal, who there are mostly women in that club, were all willing to be trained and educated in screening the girls. We are focusing right now on the girls. And what we're going to do essentially is train the teachers, train the Rotary Club women members, and train anyone else who is interested, who is in the care program, to screen for and identify common mental disorders. The more number of people we train and the more number we revisit to keep up the training, they will then be told to train others. So we're right now focusing on one school, but the idea is to roll it out across all of Guatemala. Right now, it's simply doing a train the trainer program. We will compile the number of people trained. We will do a before and after education assessment, and we will also identify the number of girls who are willing to talk about their illnesses and are referred to the county hospital for care. So we'll look at all of the stats of how that goes, but we're also going to be able to evaluate how did the training improve the knowledge base of the teachers and their attitudes and beliefs about mental illness. We can quantify that.
Yeah. So my question to you, Geetha, is once you raise awareness in the community and you train people, you make them aware to understand the signs and symptoms and to refer them to the county hospital. Now, who is going to manage that rush? Because you said there is only one psychiatrist and one psychologist. So
there's a psychologist.
How do you prepare for the access to treatment?
Yeah, so that's the second part that we're going to be working on. We have to strengthen the infrastructure that receives these girls and provides care. So we're working with the local, there's only one university there, and one of the primary people on our grant is the medical director of that department of psychiatry at the university. So they will also be providing support through their residents for these girls. Previously, they haven't been identified, they haven't been sent anywhere for care, and they haven't been treated. Now we have to strengthen the infrastructure that requires people to be, that identifies the girls. The next step will be to make sure that people who receive them are capable of treating them. Now, it so happened that in some of these places, there were people equipped to care for these girls, but they never were reached. Nobody accessed them. So there are three parts to this infrastructure. One is getting the separate groups in the community talking to one another, making sure we have computer or digital platforms where they can share information. And three, increasing the capacity building in terms of the community to take care of the girls who are referred to them for care.
There are two hands going up.
Yes, so first, Glenda.
Yeah, please.
Yeah. Yes. Hi. Hello, everybody. Hi, Geetha. Thank you for what you shared. So I'm in the Philippines, and listening to what you had presented, it's a little bit of what I see here in the Philippines, in the rural part. And so my question was actually what our chair had asked is what then happens once, you have the trainers and they're diagnosing, and what then happens to the people who are getting diagnosed, right? So you've already answered the question. But then I guess my question, which is the problem here in the Philippines, is the medication, right? So these how do they afford if they needed that treatment? What kind of support do they get? in terms
Yeah.
of
So the way we built our program in India was similar. It started this way. And then we had to find philanthropists. We had to apply for further grants. We had to, and I gave plenty of my own money, but we essentially found a way to work with the local system to provide low-cost medicines. Now, one of the things we are not doing in Rotary so well is not working with other systems of care. So to give you an example, I'm part of the Rotary action group on the Rotary Fellowship of Healthcare Professionals. Each of us has some project in Guatemala, let's assume. We don't talk to one another. We have no idea what the other group is doing. And we're working here in the US on getting all of us who are working in the Organization of American States, which is all of Central America, to work together. So let's assume we have, one of our directors in Rotary is Emmanuel Katangale in Uganda. Emmanuel has a drug manufacturing industry there. And frankly, medications manufactured in India are the cheapest, 1/30th the cost of what it is in this country. So we've got to find a way to link people who are Rotarians, who are business people, and who can manage to service the industry by giving the medications. And then I've told Emmanuel, and he said, oh, let me work with you. I have also partnered with another group called RO, Global Health. RO stands for Rest of the World. Global Health, it is a medication manufacturing concern here in the US, but they get their medicines manufactured in India and then shipped to places in African countries where they're treating epilepsy. So it is possible if we work together. Now, it takes effort, it takes industry, it takes persistence, and it will come through. But this is just the first phase. We can't solve a whole country's problem by one global grant. We can't. But all I'm saying to you is they feel very encouraged that we've even done, we did an enormous amount of work in just 10 days. That doesn't happen ordinarily, but Herman and I push very hard. Sometimes I'm resented for it because I'm a very hard driver. So you can't promise somebody something and leave those girls hanging. So we went in there, we've established this. We will continue teaching online, and Herman is going to go out there for another visit. So we applied for a district grant for the needs assessment. It was approved, it's completed. Now we're applying for a global grant. So this is a stepwise progression. If you get many interested parties in the Philippines who already are Rotarians with some means and ask them for help, it will happen. But it takes many more people than just one individual to get it rolling, okay? So all I'm saying is in Kenya, finally, after 5 years of our persisting and pushing, the Ministry of Health took over the clinic, which makes it a big difference. So we're hoping that in Guatemala, the health system will take over this process. They just need to be shown the way and the fact that this can be done. And we have promised our support in a continuing manner. And I'll make sure we get funding to send it there. I mean, I'm constantly working on begging people for money. Jay is way better than I am at this. And people give. People will give. If I show the pictures that I just showed you, people will give. So I always have hope. That's what keeps me going in my old age, okay?
We have Vivian.
Vivian?
Vivian.
All right, thank you. I'm Vivian. I'm from District 9104 in Ghana. So I heard Geetha talk about the fact that the PHQ 9 was translated and reverse translated. And you also mentioned that the girls were protective of their family. Right. And that brings about the cultural issues and mental health. So I don't know how that was handled or that will be handled going forward. Since this was a needs assessment. So that's one question. The second one is, were they diagnosed with intention to treat? Because I didn't hear about talking about any intervention, and some people had severe mental health depression. So how was that handled? Thank you for the opportunity.
Okay, so the first question is the cultural component. It's very, very important. If you don't address the cultural component, your project can't move forward. In that particular culture, to be honest with you, the girls are second-class citizens. And they are, because of severe poverty, they believe their way out of poverty is to become somebody's spouse at the earliest age possible. This happens in the north of India. It happens in rural Kentucky, rural West Virginia. They have limited understanding of what it is. Essentially, they don't own themselves, meaning they have no sense of self. It's only in the service of what the family wants. That essentially is the problem. Now, that's not going to be changed overnight. What we want them to do is trust the treating team that goes in there, or the assessment team. And for that, we need the teachers' faith in us that we are trustworthy. Steve was a huge process of facilitating that for us, because Steve is very well trusted, very well respected in that community. So he's a primary stakeholder there. Now, Jose, who is the psychiatrist who's also the chief of the medical school and the local labs, he is a key person to have on our side, because Jose as well is someone who could put us in touch with all the different factions in the community that provide medical care. And Jose has bought into this and will make sure that the girls that we identified as suicidal are taken care of. There were not a whole lot. There were maybe 3 or 4, and those will be followed up, and they will be referred to the local clinic, and they will be treated. What was your last question?
Okay, so I think that's basically it that you've answered, because I was asking about follow-up on treating the people who were identified, especially if somebody has an active suicidal ideation with a plan. It's not enough to be just diagnosed and left like that. So
absolutely, I agree. I agree,
Yeah.
100%. So they were not left like that, but I'm going to be talking to Herman tomorrow. I'm going to bring it up again. Because of my language difficulty, I can't communicate this, but he can. And by the way, he's been in touch with numerous Zoom calls with all of the people in the community, but I will certainly bring it up to him, Vivian. It's of great concern to me. So a couple of other things we put in place. These girls live in dorms where they don't have a room which is enclosed, and they're visible to others. It's like an open dorm room with beds. So they can't do anything to harm themselves without somebody else noticing. That's one. The people who are there as resident teachers have been put on high alert with these girls. And Jose has been informed about the care for them, but I will certainly check up on the 2 girls that Herman was concerned about. And thank you for bringing that up and bringing it again to my notice.
Thank you. Thank you so much.
Thank
Geetha.
you.
Thank you. Thank you very much for that wonderful presentation on Guatemala.
We have one question in chat box from Rose.
Okay. All right, go ahead.
Is the Train the Trainer a package? Is it an available program?
So what we're going to do is, train the trainer model has been used in a lot of research in many areas, not just like the way nurses train others to do CPR. That's the kind of thing. So we did one train the trainer about a year and a half ago here in September for youth, where we trained them to administer Narcan to their fellow students if they passed out due to fentanyl use, because it's only a few seconds before the person dies. So we trained them to do CPR. We trained them to actually administer Narcan, and we gave them a Narcan kit. Now, this is not a complicated thing. They can then train others. So essentially, what happens is if a student sees somebody passed out, they've got the Narcan kit, they administer the Narcan. Nobody can have a negative effect from the Narcan being administered, but they essentially saved somebody's life. We trained 100 students. They were all into it. So that model is replicable in any part of the world, but you have to watch them. You have to do some relearning for them and then evaluate to see if they got it right. So that's how CPR got CPR spread as a way to save somebody's life across the world. That's possible to do.
Yeah.
But with Herman, I'm planning on figuring out a toolkit for us for this kind of activity for RAGMHI. The second thing I wanted to also talk about is because I'm on Holger Kanak's committee for health initiatives on the advisory committee. We all work in silos. I think there ought to be a way for us to work together. So for example, somebody goes to a village to look at malaria. There's depression there too. Malaria affects the brain. I've seen a lot of psychiatric disorders and cognitive problems arising from malaria, cerebral malaria. But those doctors treat the malaria, they don't look at the psych part. I think we're all doing things in pieces, and we should all be a multi-dimensional team that goes into an area to treat them. And I'll come up with the toolkit, but Herman and I are planning on doing that.
Okay. Thank you so much, Geetha. Thank you. That was
Thank you. Thank you all.
It was awesome work and amazing. Yeah, we can clap for her actually. That's a good thing. So may I request Sauresh now for inaugurating his newsletter. He's the editor of the newsletter since many years, but he has reimagined it and worked hard on it to change its format and put some more ideas into it. Sauresh, will you do that, please? I
Yes.
think it's the best time
So
to just inaugurate your new
we
newsletter.
have 3 founder members, Geetha ma'am, Rita ma'am, and Bonnie ma'am. So all are here. And in front of them, we are, bringing in the new version, which you will receive either tonight or maybe tomorrow morning in your inbox. So here I'm sharing my screen again. Please let me know if you can see the.
I can see it.
So this is the name of the newsletter has been given by our chair, Metamorphosis. Rita ma'am has given this. And with me, we have a good team which is currently working with us. So here is our team which we have, and we are looking forward to more people to join us and help us to, make it more informative, more helpful for all of us. And we are looking for the stories, the projects from chapters, articles from all the members. And this will be great if we can, contribute to our own newsletter. We can have a good informative source for all of us, where whatever Geetha ma'am shared just now, it's a very good resource for all of us. So if we have already published once, I think, Geetha ma'am, this project in the newsletter earlier. And so if we can share our own project stories or the report format, so that will help other district, other clubs to implement the projects. So this is all from the newsletter team. I think we have Devashish in the call, Sushanta in the call. So thank you. Sivangi is also there. So we all are here to make it better with your help. Thank you so much.
Thank you, Sarish, and
Thank you.
congratulations.
Thank you. I mean, it looks lovely. Thank you so much.
Congratulations. That's a wonderful improvement going ahead. And as Suresh said, from my side also, I would request you to write your reports, your project on which you're working, because that is what we want to put in the newsletter. Highlight your work, your good work, for people to read and for people to maybe replicate and get ideas. Like we got a lot of ideas today from Geetha's work. So that is the main thing. And the second thing is that we would be working on some theme. Like this month, Suresh has taken the theme of maternal and child health. And we have a few articles on that by contributors. And we would like all of you who like to write to contribute to it also. We will be taking out the list of the theme for the month, and you're most willing to write to us to say, yes, you would like to contribute. So please get more involved in the newsletter with your project reports and your writing. And if you have any more ideas, please share them with us. So thank you for that, Suresh. And would you now like to talk about what Alan wanted to do with teams and committees, Suresh?
Yes, ma'am. There's not much time here, so I'll just give a brief. Then we will send an email to all the members with the more details.
Just
So
take two to 3 minutes, and we can wind up.
Yes, ma'am. So we have teams on different areas, like as we were discussing, toolkits. So we need people to join the toolkits team to improve the toolkits, then make it more feasible, more successful with your ideas and with your work you are doing. Then we have a team which is the committee, the chapter committee, where we are looking for more district chapters, more engagement from district chapters, more communication with the district chapters. So there we have a committee as chapter. So toolkit is one committee where anyone who wants to join in the programs toolkit section, they can join. Then chapters we have where people can join and improve the quality of communication we are at this moment, or any ideas you can share. So we have a chapter committee. Then we have a committee membership which Alan has thought of, where we are thinking of like how to improve the membership. First, the retention of members who were there and who will continue. Then we are looking for good quality and in like more engaged members for our RAGMHI chapters as well as RAGMHI board. And then like chapters, trying to help us with better members, better teams who can work for the projects apart from their district, they can help to other district chapters. We need a very, very good technical team for the website, because we have to do a lot of work on the website front. So if anyone of you can join, if you know anyone who can help us, then join the website team. And last but most important is the public image team, where we have to showcase our work. We have to showcase what we do in our social media pages, in whatever blog sections, wherever we can work. So a good amount of work we need in the public image sector. So these all options will, form in a Google form, and then try to share with everyone. You can fill it up. You can share your ideas. You can share your comments on that. So this is much about this, and we will send a detailed mail later after I, have a discussion with Ella. Thank you, ma'am.
Right. Thank you so much. So I think we are already at the end of our, we have crossed the 1 hour. Thank you for all your cooperation. The last thing I would request is members who would like to make presentations of their projects, like Geetha did today, they are most welcome to write to us that how much time you need and what would be the subject. And because in every month we have these open meetings, and we will schedule your presentation according to mutual convenience. Thank you so much. Thank you for being here today. Thank you. Anybody else who would like to make a final comment? Otherwise, we are.
Thanks. Nice seeing everybody.
Thank you, ma'am, for the nice presentation.
Yeah, very wonderful
Thanks, Suresh.
presentation. Thank you.
Thanks a bunch.
Thank you, Greg.
Nice to see Greg every month.
Yes. Important.
There were a lot of members whom I would have loved to get an introduction with. So maybe the time is less.
Yes, today actually there was no time, ma'am. I think Terry is still there if she can share anything with us.
Terry is presenting in September.
Jailor is there.
We look forward to Terry's presentation in September.
We are very honored to do this.
We are
I know
honored.
everyone will enjoy it.
Yeah.
Thank you.
We've heard about it. I think Gordon McNally mentioned it.
Yes, yes.
And
It was in the Rotary magazine in the
Also.
provider pipeline section. Yes.
That's wonderful. We'd love to hear more.